Hi, I'm Ellen Suarez, district nurse, and I'm here to give you a training on first aid for seizures. As you can see, the documents are up, and this comes from the Epilepsy Foundation in 1999. So it's a little dated, but the first aid is still generally the same. Medications have changed. We have new medications and they're nasal, which is very helpful. So we'll be reviewing those, and then we'll be reviewing the first aid. So if you look at the first page that you have, it covers the convulsion type seizures. So seizures come in different types, and it just depends on what part of the brain is affected. So if it's on just one side, usually you'll have the response on the opposite side of the body. And if it's just a partial brain involvement, you'll have like lip smacking, maybe some twitches on that side, sometimes some drooling, but it's usually on just the opposite side of what part of the brain is affected. Two types of seizures, the tonic-clonic and the absence seizures. And absence is described as a blank stare. They will be talking and then just stop talking for like 30 to 45, 50 seconds. And then they will resume, maybe seem a little bit confused, but then resume their activity. Tonic-clonic is the generalized seizure where you'll see tremors, shaking, sometimes a hoarse cry in the beginning, and then shaking and the eyes roll back, and usually the person loses their balance because they become unconscious, and so they will fall. So if you see someone having a seizure like this, it's important to protect their head and to help them down to the floor. But the absence and the tonic-clonic are both sides of the brain happening at once. So those impulses. Anyway, for the first aid for seizures, for the tonic-clonic and a generalized type seizure, the head needs to be protected. So you want to always cushion the head. If they're losing consciousness and they're falling, you want to help control the fall. You want to loosen their tight clothing. You want to turn them on their side. That way, if they drool, vomit, something else, they will not aspirate. Time the seizure. Yes, I still wear a wristwatch. So if you can time the seizure, then you will know how long it is, because that's very crucial in treating seizures, is how long is this person having their seizure. Don't put anything in their mouth. That was an old practice a while back. And look for an ID. A lot of times people don't have ID bracelets or pendants because they cost extra money. Don't try to hold them down. Don't try to restrain them. They will be tremoring or any kind of movement. Just protect them from any dangers, any hazards. And as the seizure ends, then they start to wake up. They start to regain consciousness. Reorient them to where they're at. Let them know that who you are, and ask them if they know where they are at. If they're not sure, let them know. Say you just had a seizure, you're at school, you're going to be okay. Be reassuring and calming. Offer help if they need help. So if they did hit their head, if they did bite their tongue, and that can happen, you can help them. So most of the time, a seizure is not an emergency, so they don't have to be transported. The next page is the first aid for seizures for a complex partial psychomotor or temporal lobe. So this is where not all of the brain is involved. So you'll see blank staring, sometimes chewing behavior, a fumbling, like they might be pulling at their garment. They might be pulling at, picking at somebody else's garment too. They might be wandering, like not looking confused, not knowing where they're going, shaking, sometimes confused speech. People might think that they're under the influence of something, but it can be very likely seizure activity. Follow the first aid steps. So first aid steps would be just guiding him back and having them sit down, because we don't want them to walk and then trip and fall and hurt themselves, or to go outside or in a dangerous area like a parking lot or a street. Explain to others she's having a seizure. Block hazards, so don't let them go someplace that could be dangerous. Speak calmly, because they don't respond that they're hearing you, but they could hear you and they could act accordingly. It just depends. The first aid for seizures, you have tracking the time. Tracking the time is very important. It helps with treating the seizure. It helps to give the practitioner an idea how long these seizures last. And so it's very valuable to track the time, how long the seizure is. Also included in your packet is a seizure observation record. And this record, let me see. This record is used for when you have a student that has seizures in the classroom. And sometimes they're very brief, but that way you can help the parents, and then they take this information to the practitioner and help them know how often the student is having seizures. The diagnostic test that's used for seizures is an EEG, so an electroencephalogram. And so then they measure the brain waves, and then they can tell, is there seizure activity happening or not? The page we're going to cover now is how is epilepsy treated? So it talks about medication. So most people achieve good seizure control on one or more of the variety of medications currently approved for the treatment of epilepsy. And so if a student is having breakthrough seizures, then of course they're going to adjust their medication. So we work closely with the parents and then also the providers to help them gather as much information as possible, so that the student's medication can be adjusted and we can prevent seizures. Surgery, some types of surgery may be used for patients whose seizures don't respond to medication. They can do like an ablation, which means like a little freezing or a little heat treatment to a certain focus that's in their brain. And so they can treat that, and sometimes that's very successful in stopping their seizures. So, and then it also talks about a lobectomy, so taking out a significant part of the brain. And these can be used when the seizure focus can be determined, and removal of all or part of the affected lobe of the brain can be performed without damage to vital functions. Vagus nerve stimulator. So that's a little pacemaker-like device, and it's implanted in the chest and with a lead that attaches to the vagus nerve. And so this device, when it's programmed, they can stop seizures with this device. So it says up to 2/3 of patients whose seizures do not respond adequately to medication see improvement with this method. And then ketogenic diet, I haven't heard of any of our students being on this, but it has been shown to help. So they eat a low protein, low carb, and low protein diet. So it's shown to benefit as many as 2/3 of the children who can maintain it. Anyway, first aid on handling a seizure. So the bottom portion, back to this, types of seizures, it just gives you an overview of the types of seizures. And then the former names. So people will say, oh, that's a grand mal. Well, now it's called a tonic-clonic seizure. So this gives you the former type names, and then also the current language that's used to describe these seizures. So how to handle a seizure? Well, number one, don't panic. And direct the person away from the hazards if they are upright and still moving about. So you want to protect them from hazards. If the person is having a convulsive seizure, then put them down on the ground and turn them to their side and cushion their head. Remove glasses, tight clothing. Don't put anything in their mouth, especially your finger. Don't give liquids or medication. They need to get through the seizure and make sure that they're alert, oriented, and able to sit upright. Don't restrain them. Don't hold them down. Don't restrain them on any part of their body. And remain with them until the seizure is over and that they are able to verbalize where they're at and understand what's going on. A lot of times people are tired after a seizure, so they will want to sleep. When to call 911. And this covers what the emergency conditions for a seizure. So the seizure lasts longer than 5 minutes. And person has not had any history of a seizure. The person doesn't resume their normal breathing after the seizure ends. And there's no medical ID, so no known history. So again, the first time seizure. If there's an obvious injury, so they hit their head, they fell on an arm, some part of their body is injured, then you would want to call 911 or take them to the nearest emergency room. If they're pregnant or they have diabetes, if the seizure has happened in water and there's a chance of them aspirating. And then lastly, if they request an ambulance. In the school system, if the parent requests an ambulance for seizures, then we transport them. For all of our students, we do an action plan. So I will cover that in just a minute. So the next page is most seizures. This is information for teachers, but it covers the basics of of seizures. So they're not medical emergencies. They're often aware that they are having a seizure. So a lot of people have an aura. So they will have like sometimes a headache before a seizure. Sometimes they will feel really tired that day. They will feel maybe a little tired, maybe a little dizzy. There will be some sort of seizure feeling or sensation. Not everyone has that though. Sometimes students say that they have no idea when they're going to have a seizure. They just happen. Sometimes, so epilepsy is not contagious. You can't spread it. It's not a form of mental illness. It is a neurological disorder, but it does not, it's different than mental illness. It very rarely does anybody have any really negative, experiences like death. Usually it's in conjunction with another injury. So that's why we need to protect them from additional injury. They can't swallow the tongue, but they can bite it. So just being careful with that, and don't put anything in their mouth. So epilepsy does impact their education. That's very important to remember. So before a seizure, they're not going to remember that time, that portion of time, because their brain is already transitioning into the seizure. Of course, not during the seizure, they're not going to remember that. And then after the seizure, they can have difficulty with memory too. So you want to keep that into consideration when in the classroom, especially students that are having small, frequent seizures throughout the day. Knowledge is difficult to retain when you have these periods of unconsciousness throughout your day. So after a seizure, coursework may have to be retaught. Seizure activity without obvious physical symptoms can still affect their learning. Medications may cause drowsiness, inattention, concentration difficulties, and behavior changes. Students with epilepsy are more likely to suffer from low self-esteem. They want to be normal. They want to be like their friends. School difficulties are not always epilepsy related. That's true. Sometimes students have comorbidities, meaning they have more than one condition at a time. And so they're dealing with other issues in addition to seizures. Seizure recognition and first aid, this is an additional resource. Most of these things were already reviewed, so this is an additional page for you to look at. Anyway, and then first aid for seizures. So this is a simplified version to help you look at stay calm. Seizures don't last that long. Prevent injury by moving any objects out of the way and helping the person down to the floor. Pay attention to the length of the seizure. Make the person as comfortable as possible. Keep onlookers away. Do not hold the person down. Don't put anything in their mouth. Don't give any water, pills, food, juice, anything, nothing until they're fully alert, conscious, and talking to you. If the seizure continues for longer than 5 minutes, then call 911 and be sensitive, supportive, and ask others to do the same. The last page is the seizure action plan. And this is what we do for all of our students that have seizures. We has their name, their identifying information, and then we give a little bit of history as to when they first had a seizure and what type of seizure that was. We describe it. Sometimes there's a lot of activity and we can't fit it all on the form, but we put usually we'll put the first seizure and then we will describe the most recent seizure activity. That way, those who see this plan are aware. Students that have active seizures, we update this seizure action plan approximately once a year. If they're not having active seizures and it's been at least 2 years without a seizure, we will leave the last action plan formulated in the document section on ARIES, but we usually will not update that seizure action plan unless they have another seizure. So you have identifying information, emergency contact, seizure information, the type and the duration, and sometimes students have 2 or 3 different types of seizures. And then we ask the parent. So we formulate this plan with the parent, and in addition to their school orders that talk about what kind of medication they need and all the parameters for that. So the student's response after a seizure. So we describe the triggers, warning signs, and then response after the seizure. So that way teachers and school staff will know, is this new and different behavior, or is this something that they've experienced in the past? Do they have do they need to leave the classroom after a seizure? I would say that's pretty much 100% of students. Most students, unless it's an absence seizure. An absence seizure would be just the blank staring, and they most of the time can stay in class unless they're not feeling good or they have a headache or something else is going on. Emergency response. So we look at on the right side of this, and we have the basic seizure first aid. So keeping calm, don't restrain them, support them, put them on their side, and record time how long the seizure is, and then protect the head, keep them away from any objects that could be threatening, could be injurious, and turn them on their side. Okay. And then what is an emergency? So no seizure in the past, so first time seizure, then one lasting longer than 5 minutes. Then if they're injured or they have diabetes or they had a any breathing difficulties, or they were in or near water. So those are noted. In the center, you have the seizure emergency protocol. Do we transport the student or not? And that is up to the parent. Whatever the parent wants, within reason, that is what we put on the plan. So contact the school nurse, and that would be one of the district nurses, and then call 911 to transport. The third is to notify the parent. So you want to get 911 on their way first, and then you can call the parent. Usually the parent is closer and easier and fairly easy for them to respond. Then give the emergency medications as ordered. So you need to check the order. Is it after 3 minutes? Is it after 4 or 5 minutes? Those are usually the orders. And then there's also may repeat orders. So if a student gets their medication once, but they either go back into seizure activity or they never stopped, then it will tell you when you can repeat the medication. Because many times the medication comes with 2 devices. So I have an example of one here. This is called Valtoco. This is a nasal form of diazepam, which is the same as Valium. So this medication right here comes in a nasal applicator. So we do have training devices. So if you are to take a student with seizures and this medication, we will do an in-person training with you and let you try out the training device. We also have, there's another medication called Nizolam, and it is a similar drug to the diazepam. It's midazolam, and it's a sedative. So they're both sedatives. They're going to calm down the seizure activity, but they do cause drowsiness, sleepiness. So that's the biggest side effect.
Valtoco is given in the nose, nasal only, and can be prescribed at different doses based on patient's age and weight. Each Valtoco only sprays one time and cannot be reused. Do not test or prime the nasal spray before use. Each dose of Valtoco is provided in an individual pack. Use all the medication in one pack for a complete dose. If prescribed to do so, a second dose may be given at least 4 hours after the initial dose if needed. 1 blister pack equals 1 complete dose. The patient does not need to breathe deeply when the medication is given. Lay the person on their side or back if possible. This can be given to a person lying down, standing, or sitting. Hold Valtoco with your thumb on the bottom of the plunger and place your first and middle fingers on either side of the nozzle. Insert the tip of the nozzle into one nostril until your fingers on either side of the nozzle are against the bottom of the person's nose. Press the bottom of the plunger firmly with your thumb to give Valtoco. Remove Valtoco from the nose and throw away the nasal spray device after each use. Make note of the time the dose was given. If giving the 15 mg or 20 mg dose, repeat the previous steps and use the second device in the other nostril to give the full dose as prescribed by your doctor. After giving Valtoco, stay with the person and watch them closely. Keep or move the person on their side facing you so that you are able to watch them. Call for emergency help if any of the following happen. Seizure cluster behavior is different than other seizure clusters the person has had. If you are alarmed by how often the seizures happen, by how severe the seizure is, by how long the seizure lasts, or by the color or breathing of the person. Throw away or discard the used Valtoco. If needed, a second dose may be given at least 4 hours after the first dose, using a new pack of Valtoco. Do not give more than 2 doses of Valtoco to treat a seizure cluster. A second dose should not be given if there is concern about the person's breathing, they need help with their breathing, or they have extreme drowsiness. Do not use Valtoco for more than 1 seizure cluster episode every 5 days. Do not use Valtoco for more than 5 seizure cluster episodes in 1 month. Thank you for watching, and make sure to reach out to your pharmacist or provider if you have any questions.
So we go over that, we review that with anybody who's going to travel with the student, specifically like in the elementary setting, it would be that all the teachers that have that student, and we would review that. Also, what any other special instructions. We designate which hospital to transport them to, and then also anything else. And it can be written in. We don't have to go specifically by only what's in the little boxes. The next part is for medications. And so it shows you put a check mark in the emergency medication section, and then a dosage, time, everything that's on the pharmacy label and what's on the med in school form. A lot of times the neurologists, like at Valley Children's, they will submit orders, and then we also have the parents sign the medication in school form, so then they understand our policies and procedures, and it also serves as a release of information and a release of liability. But we follow those orders in accordance with what's on the pharmacy label of the medication. There's a section here, does the student have a vagus nerve stimulator? Yes or no? We have not had one in our school district since I've been here. And special considerations and precautions. So school activities, any special instructions, they go right there. So, and then it calls for the parent signature. We sign underneath the parent. And then this becomes the plan for school. And we upload it into Aries. We train those that are at the site that have daily contact with the student so that they are aware of what the plan is. And I think that that's it. Thank you.